So these are the splint supplies for a short leg splint that we use at Harborview Medical Center. We use 4-inch cotton web roll. We use extended, generally 4 to 6 inch cotton bulky Jones padding. We use 5 by 30 inch plaster. These are, 1 is 10 thick and then 2 are 5 thick each. We have our bias and tape. Those are our supplies. So this is a simulation of putting on a short leg splint in it as we do at Harborview Medical Center. We have already performed our physical exam of our patient. We know their neurovascular status. We have evaluated their leg for any wounds. We have appropriately dressed their wounds. We have gotten all of our supplies. We have water, lukewarm temperature. The splint material that we are using does not use a catalyst, so the water temperature can be room temperature to lukewarm with little concern of burning the patient. We have plenty of web roll. We have evaluated our x-rays and determined what maneuvers we need to do for a reduction. And we will begin. First thing, the patient has received appropriate analgesia, either in the form of IV pain medication, conscious sedation if required, or a hematoma block of the fracture site. My assistant will first, we'll change that. Why don't we first do what's easy in wrapping the toes. As discussed, we want to always cover the tops and bottoms where our splint is with a minimum of 4 rolls. From here, Dr. Thayer can grab the toes. You can actually grab on the outside. Good. And the holder position is very important for their ergonomics as well as patient comfort. One hand is grasping the toes, holding the leg up, and one is underneath the medial thigh, bending the knee, taking the gastroc soleus out of our deforming forces, generally of our fracture distal at the ankle. From there, we continue to pad with cotton web roll. Paying special attention to areas of pressure, including the medial and lateral malleoli, the heel, cotton web roll can be torn to avoid any wrinkles that may cause later pressure points. Special attention, as previously discussed, should also be paid to creases where too much material can actually cause a constrictive response. From there, we work up the leg with a minimum of 2 layers. Having adequate supplies is very important. Know where your popliteal crease is at the top. Minimum of 4. Go back over any areas where you think there's insufficient padding. From here, depending on the degree of reduction needed or the fracture, we can, in addition to fractures that have a high potential for swelling, add bulky padding. There you can have your assistant hold that. 1 or 2 layers just to tack this down. From here we'll go to dipping our plaster. We first start with our 5 thick plaster. Dip it in the water. Put the plaster together so that it interdigitates with the gauze mesh, laminate it. Thoroughly. Get the cross-linking. We start with the medial stirrup first, somewhat out of tradition, and also for our constant vigilance of keeping the ankle from falling into varus. Laminate. Laminate. Laminate these together. We then go to our posterior slab, which is 10 thick of our 5-inch by 30-inch plaster. Put it together. Really laminate it together. And you have your holder grasped at the bottom as well as at the top. It's very helpful at this point to put a roll of cotton over top of your plaster to aid in removal of the splint. Otherwise, it becomes very adherent to the bias overwrap we use and is challenging to take off later. Our cast techs are appreciative when we do this. From there, we use our bias. Generally start at the ankle, go around the foot, cover everything. Dr. Thayer will keep her hand where it's at. I'll wrap over her hand and then tie it in. Going up the leg, you can do a herringbone type pattern here if you wish, extending past the top. Trick is you can take remaining, let it hang, cut it there so that there's tension, and then apply your piece of tape there. At this point, while the plaster is soft, is when you would do your reduction. So a Quigley's reduction for a fibular fracture to reduce the mortise would be pressure low, pressure up higher on the metastable flare, and then some counter pressure, which your assistant can provide higher. And from there, you wait until your plaster is firm. You can use a mini C-arm at this point to check your reduction. In unstable, very unstable fractures, it's beneficial to sometimes do that at the beginning to make sure that you can get a reduction before you apply splint and padding. Once your padding is firm, a stack of sheets can be useful to place underneath the patient to continue to disengage the gastroc and soleus. It's also very important to keep the patient from falling into an equinus at the ankle and plantar flexing while the splint continues to harden. And always after you're done, never forget to put up the side railing so the patient doesn't fall out of bed. After your splint material is hard, you can apply the appropriate tape. Make sure to check all areas at the top and bottom of your splint to make sure that there is no splint material that is sharp or pointy or contacting the skin, as that can cause burns, skin erosions, ulcerations. be able to see the toes, all of them, so that you can perform a neurovascular exam. Post-splinting. In the case of any neurovascular changes after your splint has been applied, it may be advisable to remove the splint, to evaluate for any areas of compression. From here, we just take pride in our work as we dress our splint and secure it so that the bias does not fall off. Medial to lateral. Keep the angle from falling to varus. Tape can be constrictive as well, so it's generally not advisable to wrap circumferentially with even tape. Common areas of breakdown are going to be, of course, the heel. Out. That. Thank you. There. Always after splinting, perform a post-splinting neurological exam. So common breakage points on a patient who may be intoxicated or fighting your reduction are, of course, they're going to want to contract or flex the ankle. So you'll get breakage here at the posterior slab where it alternates from the heel to the foot and the midfoot. People will flex through that. Even when a splint is semi-dry, it can still be broken relatively easy by a patient who's flexing. Other places that you really need to pay attention, of course, are back here in the popliteal crease. You need to make sure that your plaster is well padded and well covered in this area. You can feel that. Tricks that you can do to alleviate this is when your plaster comes up, you have your splint material that extends past that. You can actually turn that down, and when you're wrapping your bias over top of that, you can cover that up. Once again, you can tuck that in. Now you have nothing that is sharp or pointy driving into the skin to cause ulcerations. There's also the popliteal crease is free. Even if she bends, popliteal crease is still free and amply padded there with nothing hard. Other modifications that can be done with the short leg or long leg splint include windowing. Windowing is helpful in the cases of having to do neurovascular exams, compartment checks. To do that simply, your plaster ends over the anterior tibia. You can, caution not to cut the patient, cut out a window. Pull back your plaster to expose tibia. From here you can somewhat adjust the plaster as it's drying to provide a window so that you can stick your fingers circumferentially around to feel compartments for any tense compartments. This is just one of the components of a compartment check. Take pride in your work. Make sure things look nice. The toes are able to be seen. And the patient can wiggle their toes. The dorsum of the foot can be palpated. If a Doppler ultrasound needs to be done, the splint can further be modified. Taking care not to cut the patient. To a position where the dorsalis pedis can be Dopplered and or palpated. And then splint beautification can resume. We're going to be applying a long leg splint. This is commonly seen in anything where you need stability above the knee for any rotational issues. Primarily, we use this for tibia fractures, tib-fib fractures, plateau fractures, or pilons even, where there's going to be rotational instability if you just splint with a short leg splint. As always, before any splinting, make sure that you have done a thorough neurovascular exam, including ABIs if that's applicable. You have reviewed your x-rays to determine what your deforming forces may be. You have all your splint material readily available, any C-arm if you need that to evaluate your fracture while you're splinting. You have got appropriate analgesia for the patient, which may include IV or oral medications, conscious sedation, or hematoma blocks. Okay, generally at Harborview, people are placing box splints prior to any splinting. Like to do what's easy first. As always, wrap the tops and bottoms of your splint with a minimum of 4 layers. Next, you can have your assistant come in and elevate the leg. Generally, we grasp around the toes as well as underneath the medial thigh, bending the knee to take any deforming forces by the gastroc soleus out. Next, we work our way up. You are the boss of the web roll. You can tear it any way you possibly need to avoid getting excessive wrinkles, which can actually cause pressure points. Pay special attention to those potential pressure points, including the heel, the medial and lateral malleoli. It's also very important not to get too much bulk where there's creases, as that can cause compression. We work up the leg with a minimum of 2 layers. We've also, prior to any splint application, evaluated, cleaned, dressed any wounds or burns. Try to get up as high as we possibly can. We do this typically in 2 different segments, the short leg and then extension of the long leg. So now we will apply our short leg. Make sure we've got adequate padding. We dip our plaster. Laminate, laminate. Generally leave these a little bit looser and they extend up a little bit higher than if we would with just a short leg. And these are, I mean, wetter, so they don't dry as quickly. So we're going to need to laminate our long leg extensions into our short leg. Laminate down here. Posterior slab, which is of course 10 thick as compared to the 5 thick ply that we use for our medial and lateral stirrups. Making sure that doesn't extend into the popliteal crease. Bring it up to the end of the foot. As we do in our short leg, it's helpful to wrap over the plaster to aid in its removal by when it comes time in the operating room. Special attention is paid. We don't extend it up too high though, because now we are going to transition to our long leg. At this point, it's generally easier to put some padding down to aid in your assistant. And we will continue to work up the leg. Your assistant can help them from externally rotating. In the case of a pilon, you may do a provisional or a reduction prior to applying the long leg extension. Generally on the long leg extension, you want to go as high as you can so that you are getting that rotational stability. Up on the thigh, it's sometimes easier to use the bigger 6-inch web roll. It's always good if you can get the web roll a little bit higher than where you're going to put your plaster as well, so you can turn it down to avoid any pressure areas. Popliteal crease is an area where, the plaster can ride, so if that needs to be turned down, you can turn that down, debulk a little bit there if you need be. Next, we're going to take our, this is 5 ply, 5 by 30 inch. We fold it in half. Dip it really, keep it pretty moist, make sure to laminate it. Now we're going to do these extensions up the leg. Really got to pay attention to laminating this portion into the lower leg segment. You need to turn down the top so that it's not extending above your plaster. Do that. Really get as much as you can. Integrate that long leg extension piece into the lower leg. Get your hands a little bit wet. Interdigitate them as much as possible. Laminate them. I like usually having the bent portion up at the top so that there's not a lot of loose frayed pieces up there, and the loose frayed pieces can help down here. Next, extend it. Higher. Trying to cover really as much as we can. Then you'll have your assistant move back up. Lift the leg. Apply your bias overwrap. Go ahead and keep your hand where it is. Wrap underneath the hand. Tie that in at the bottom, then work your way up. Once again, paying special attention to the popliteal crease. The leg should not be bending as it would. So then you can actually, sometimes if it's a really heavy patient, have your assistant lower and you can continue to wrap up with the bias. At that point, you can also be doing a reduction at the ankle if need be. Sometimes the bias doesn't go all the way. Grab another one. Be prepared for that. We generally don't use plaster with a catalyst, so we have a little bit more time. At this point, you can either focus on your reduction. So another trick is you can cut the bias 99.9% of the way. It's holding a little bit of tension there so that it doesn't unravel. Tear that off. And away you go from here. You're doing your Quigley's reduction. If that needs to be with a ankle fracture or you're pulling out to length. It's also beneficial in this upper section to apply a super kind of condylar mold so that the splint does not slip down the leg. That's just broad surfaces of the hands applying pressure to the splint about the thigh. At this, it's really important to hold the plaster until it's hard, until it's knock hard, and it's not easily depressible with finger. You can at any point use C-arm to check your reduction, see if you need to do any alterations. Then from there, once the plaster is hard and you have an acceptable reduction, you can beautify your splints with tape. Once again, you always want to make sure that popliteal crease, the leg shouldn't generally be bending much at this point. Well, it shouldn't be bending. So make sure there's nothing poking right into the popliteal crease. Make sure at the tops, all the way around, because that plaster can go around, make sure that there's nothing pokey that's poking into the thigh. Thighs can swell even more. And if there's any plaster, it can really cause some damage, ulceration, skin issues. Make sure that you can see all the toes so that you can perform a neurovascular exam. Usually in this case, it's also very important to create some windows for which you can do compartment checks, as this is usually done for higher risk injuries, including tib-fib fractures, segmental tib-fib fractures, open fractures, tibial plateau type injuries. Usually after this, the patient goes up with the stack of towels underneath them because, especially in a heavy leg, they will break through the laminations. So extra care should be really taken in a combative patient, sometimes gently immobilize with pillows the legs so that they're not rolling, twisting, stressing the splint too much. And from here we secure the bias with tape. Once again, you're the boss of the tape, so if there's big wrinkles generally here, easily can cut a little relieving cut, as this is really just to keep the bias from unraveling. Also be mindful to prevent the patient from going to equinus if that's part of your goal. Just to show, if we were to make a window in this, taking care not to cut the patient, remove any plaster, padding, make sure if you do cut any of the plaster, make sure to turn up some extra padding or get extra padding to pad that as to not have any of the plaster ever contact the patient's skin. Generally, several layers are advisable. Fold it, tuck that in there. Make sure your window, you might need several windows. Make sure your window is big enough so that you can do an adequate exam. Adequate exam. Try not to waste resources too much. Easily frame out your window so it doesn't propagate any tears or breakdown in the plaster or your work. From there, should be able to easily get around to evaluate your compartments. Always take pride in your work. That is a long leg splint with a window. These are our supplies for our coaptation splint that we place at Harborview Medical Center. We have a long strand of 6-inch tubular bias. We have 6-inch cotton web roll. We have generally a 10-ply thick 5 by 30-inch plaster slab. We have our scissors, ace wrap. Then we also have a pillow or a sheet that you roll up and tape to use as an abduction type pillow if you're not putting the patient directly into a specialized abduction brace with an abduction pillow. Next, we're going to be applying a coaptation splint. This is commonly used in mid-shaft humerus fractures that are displaced or angulated. As always, it's very important to make sure you have appropriate neurovascular exam, especially in the setting of a Holstein-Lewis fracture or a distal spiral fracture of the humerus. Making sure that the radial nerve is intact is especially important, as that is well documented to be a potential complication of that fracture. Also check vascular status. The next step is make sure you have discussed and have proper analgesia for the patient. This is a relatively invasive splinting technique, so that's very important. Have all your supplies, make sure you've reviewed your x-rays, and we go from there. First thing that we generally do is on the good arm, we take our plaster or another measuring device and we measure where our splint is going to go, pretty much as high as you can in the axilla, 3 finger breadths down. Splint generally wraps around the arm and it will come up to the neck. You can always turn it back, so this is about the appropriate length. We may take off an inch. The next step is to make your padding for this. How we do this is by measuring how long, or using our measured plaster, and by about 2 inches on either end, just start layering about 5 or 6 layers of our cotton web roll, offsetting it a little to adequately cover our plaster. We do use 5-inch, the width of the plaster is 5-inch and the web roll is 6. So it does have some natural cover. We are going to need 2 of these, one for each side, so repeat the process. So now, as you can see, we have two multi-layer cotton web rolls. Next, what we do is lay them out to make a sandwich, and also prepare our long strand of tubular bias. So we'll be placing these inside. Have that ready. We take our plaster and we dip it. Be sure to wet it thoroughly. Laminate thoroughly. We take and make our little plaster cotton web roll burrito. Next, you'll need an assistant of Dr. Thayer here who's going to help me. She will take one end and roll up, stick her hand in. To the other end. Perfect. We're going to take our web roll plaster burrito and gently, to keep it from rolling, put it in the, generally in the middle, try to get it in the middle of our 6-inch tubular bias. So you feel you've got an adequate amount. Make sure it's still flat and well padded. Take it at either end. You split and tear the tubular bias. To a couple inches from the end. Helps when somebody applies a little bit of traction force. Next, so we have our burrito in the middle, two sections with two limbs that we'll be using to tie around the patient. Next, Dr. Thayer will help me. You'll know where the end of your padding is. You should still have ample padding at the end. So this is where it's a little more invasive than some of the other splinting techniques. You do need to lift the patient's arm, get the padded portion into the axilla. And then from there, there's varying techniques how to tie this off. You can come around the patient, either strap it at one of them underneath the other patient's arm. That can cause some irritation in the contralateral axilla, or you can simply go around up high. Bring the splint, cradling the patient's elbow up their arm on the lateral aspect. If you need to extend your split, you can do that. If it comes up too high, don't want to cause any compression in the neck. If you need to roll back some of your padding or your plaster, you can do that at this time. You do want it to come up a little bit past the humeral head. Extend your split if you need to. And wrap up around the patient. This one is somewhat better done if you can wrap this one, the upper one, underneath the arm to kind of get a crisscross pattern. From there, with the patient's arm cradled, so making sure that there is no sharp padding or no sharp plaster in the patient's axilla and that it's well padded. The plaster extends high enough. Like to wrap an ace wrap around. Dr. Thayer, if you can hold that. Thank you. We're wrapping an ace wrap around to hold this in place, remembering to keep it on the lateral aspect of the humerus. Keep it from going to anterior. And then from here, you can simply tuck your ace wrap in or tape it if you have it. We avoid using any metal prongs here as they can migrate and cause an issue. So keeping the arm, the plaster on the lateral aspect and on the medial aspect. Generally, these fractures in obese people or people with big chests fall into a significant amount of varus. So a valgus load is applied, so up high, and then on the inside of the medial elbow, distributing the weight with the palm of your hand, the broad surface, to not create any indentations or ripples. A valgus force is applied while the plaster sets, making sure that your plaster ends up high, and you hold that until your plaster is dry. Then to further avoid falling into varus, this is where either a abduction, a brace with an abduction pillow can be applied, or a pillow keeping that elbow from falling in towards the body or into varus, as we would say. And that can be applied. Then after this, generally a sling is applied to the patient. One of the main factors to note is after your splint is applied, it is critical to do a neurovascular exam to reassess any change in neurovascular function, with primary concern about the radial nerve and radial nerve function. As with manipulation of the fracture, it can become entangled or entrapped within the fracture site during your reduction. Let your nurses know that over the next period of time too, if the patient starts complaining of any neurovascular sequelae or symptoms, in the hand or up the arm, you should be, the physician should be made aware as soon as possible. If there is any change in neurovascular exam, the splint can be removed, and a period of watching should occur, and reapplication of the splint if appropriate. So once your coaptation splint has been applied, you can then, there's different ways to tie this at the top. For this example, we have the medial strands coming up superior, and these will be tied over top. The upper strands are going underneath the contralateral axilla and will be tied in that fashion. Not a tight but not too tight knot is recommended. It does need to not allow the splint to fall off. But with the tubular bias, there is a little bit of give, but you do need to be cognizant of possible skin compromise where there is too much constriction with patient moving or with time. Generally, our coaptation splints are converted to a Sarmento brace in a 7 to 10 days or as deemed appropriate. So these are the general supplies used in making a simple volar resting splint at Harborview Medical Center. We have our cotton web roll, cotton padding, 4-inch, 6-inch. We have 4-inch tubular bias. See, it's tubular. We have a generally 8 thick with rounded corners, which we have done. Plaster splint material, tape, and a 4-inch ace wrap. Okay, this is how we make a simple volar resting splint. First off, we have our plaster. Make a simple burrito, measuring the length, usually maybe 2 inches on either side past that. And then we just make several plies, minimum of probably about 4. We will make 2 of these. From there, simply dip our plaster, laminate it together, make our plaster burrito. There's excessive web roll that can be cut or torn off. Or just simply folded. Next, we take our tubular bias, stick your arm all the way through, grab it, being careful not to really roll your volar resting splint. Put it in there, flatten it out, and from there, you can apply a simple volar resting splint. From here, you just can simply mold your volar resting splint to generally a position of comfort for the patient. Doesn't really need to extend down the arm, so you can easily fold things back away from the patient. Area for the thumb. And then, as this is generally done in the setting of infection or for comfort for the patient, just loosely apply an ace wrap to hold it in place. Don't be over constrictive with your ace wrap. Can be taped, and make sure that they're in a position of comfort. There's nothing sharp or pokey, and allow that to dry. This can later then be easily removed for evaluation of any wounds and reapplied as long as it remains unsoiled. Okay, this is a simple way to make some weights for applying traction, primarily in wrist and forearm fractures. Very simply, we have some 4 or 6 inch tubular bias. You can tie a knot in one end. Here you use what you have. Generally, you're looking for about anywhere from 5 to 15 pounds of traction. So here I just have 2 1-liter bottles of water. You can use weights if you have those easily available. Simply stick both of them in and tie another knot at the end. There, you have a broad surface from which to apply traction with an acceptable amount of weight. We're going to be applying a long arm splint, typically in both bone forearm fractures, distal radius fractures where you need rotational control. As before, as we discussed, always make sure you have a neurovascular exam, you have all your adequate supplies, and you have reviewed your x-rays, evaluated for your deforming forces on the fracture fragments. And if you need a C-arm to evaluate your fracture, you have that readily available with lead for yourself or the patient. First thing that makes this simpler is if the patient is able, have them scoot to the side of the bed. Next, generally, we want some traction on the fracture site to keep it from compressing and utilizing ligamentotaxis. So if you have finger traps easily available, those can be used and suspended from an IV pole. Another way to do it is simply with a Curlex roll. Simply make a loop, bring it down around the patient's fingers, and pull. It'll be tight. This is somewhat constrictive, so you do need to be cognizant of that. You need to not leave your patient hanging in traction, especially if they are compromised in their ability to say if there's too much pain or if they're having numbness or tingling in these fingers. From there then, generally we do the index and the middle fingers to get some ulnar deviation, a slight amount of flexion at the wrist. You can take the arm and with that little cinch knot there, abduct their arm to make it easier for yourself and suspend their fingers from an IV pole, sometimes the overhead lights. Make sure that this is very secure at the top by wrapping it around itself a million times or tying a knot. So next, to aid in your reduction, primarily of a distal radius fracture, you can use traction. But before that, it's very beneficial to actually wrap the top of the arm where you'll be extending your long arm splint. Always make sure that you have a minimum of 4 layers at the top and bottoms of your splint. From there, it's easy to apply your traction. It's nice to have a broad surface and let that hang. And it's already padded, so we'll be able to cut that off easily. You do need to be careful if you have a ring stand where it is pressing against the patient's skin. Be cognizant of that. From here, sometimes we do leave patients in traction for a period of time to allow distraction and relaxation of the muscles and the deforming forces. You can also at this time easily bring in a C-arm or a mini C-arm, check your fracture alignment to see if you have maintained or an acceptable amount of length, rotation, and reduction of your fracture. From there, we generally use the smaller web roll and wrap, starting at the wrist, up the hand, making sure to avoid any areas of wrinkles if we can, as those can cause compression. Like we said, really a minimum of 4 at the tops and the bottoms. Should also adequately pad between the thumb so lots of different techniques for this. You can make little pants and wrap that around the thumb. Another technique to kind of double your padding at the top. So just take it, roll it in half, and wrap it around the top. You do need to know where, be cognizant of where your padding is going to be ending. So where your metacarpal heads actually are, you have your knuckle, so it is pretty high up on the back, but then also on the front, it's deceiving how high you do need to go, because it's not just, you can't simply stop right, at the distal or the proximal palmar crease. You can bend the finger to actually see where it articulates and where your metacarpal head is. So you do want to extend to that level, or past that level slightly. From there, it's easy to continue down the arm, minimum of 2 layers. You get to the elbow. You do have your medial and lateral epicondyles, which are at risk for pressure, as they are bony prominences. So pay, as well as your olecranon process. So pay special attention to those areas and pad them adequately. Also, watch out that you don't get too much material in the cubital fossa. If you do, easy, pluck, 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 pluck. Throw that out. You can even go down to skin and then just put a piece over top to tie it all in together. From here, we'll take our plaster, and starting with our one that we have specially made that has a little bit of a thumb recess. Laminate, laminate. Apply that, making sure to know where you end at the top. Around. Proceed to your dorsal. Make sure to be cognizant of where you're ending. And since we have already got our traction on there, which is aiding in our reduction and generally in distal radius fracture, getting our length that we desire, we actually keep our traction and padding on there, coming up high, know where you're ending, and actually leave that under, we can leave that underneath the splint. Because that's helping us. So we'll let it help us. Next. Here, this is what's taking away rotation of the farm, making sure we're good at the tops and at the bottoms here. So wherever you have intersections of plaster, laminate them together. Cover everything up so that we're helping out our cast techs or whoever has to take this off later. Then from here, you can even wrap your bias. Generally, I'm not a fan of cutting holes in bias. I feel like that is a potential to shift, cause constriction, especially around the thumb. So it's easier to not do that. You can double spin, go around, and you can move your bias down the arm. When you do come to this area, it's very simple to stop. Generally take the bias, tuck it underneath the bed or underneath the patient's arm a little bit to hold it there. And from here, you can, with your traction still in place, or you can cut your traction. You can do your reduction maneuvers. Generally, we adhere to the AG maneuver using ligamentotaxis, so pushing for a distal radius fracture, really at the carpus and above the fracture. Broad surfaces as to not create pressure points with fingers or indentations. A little bit of a kind of a 3-point almost, but using ligamentotaxis for like a dorsal distal radius fracture. Reduce. We have traction still, so we should be maintaining our length. And from there, it's very, very important to hold the splint material until it's hard, especially in distal radiuses, and with this long arm splint or short arm splint, it's easy for you to lose your reduction if you don't hold it until the plaster material is actually hard. And this can take, with non-catalytic plaster material, a good 10 minutes, but it's worth maintaining that reduction. Always here, make sure you don't have more than a 90-degree bend at the elbow, kind of 90 degrees, 80 degrees is advisable. Over flexion of the elbow can actually potentially lead to compartment issues or constriction in the setting of a fracture. Then once our plaster is hard, it's very simple to take your scissors back to where you were at your traction bottle and simply cut those off. It's just bias that we had underneath there, so we can just simply continue to get bias up the arm. From there, another simple technique, so your bias doesn't unravel. Cut it 90%, 99% of the way. Let it hang. That pulls it down. And you simply tape over top of that. Pluck the remaining end off. You don't have to worry about your bias unraveling. And then from there, you can release the fingers, either from the finger traps, bring the patient down. Always after splinting is complete, do a thorough neurovascular exam. If there's a negative change in neurovascular status, it may be worthwhile to remove your splint and restart. Look at your splint, see if there's any place where you missed. If there is any place where you missed a little bias overwrap, it's very simple to overwrap on top of that, as we can do right now. Generally, you don't want to make sure it's covered the first time. And then from there, it's very simple. Take pride in your work and beautify your splint. You can also do this while your patient's hanging. splint should be hard. It can also help to here at the thumb to allow some mobility carefully without cutting the patient. Free up the thumb, cut away your dog ears. Pluck that away so that they can easily move their thumb. And some tape. Afterwards, always check the top and bottom of your splints to make sure that there's nothing pointy or sharp that can dig into the patient and cause skin irritation or ulcerations. There is a long arm splint. We'll be going through how we commonly put on a short arm splint at Harborview Medical Center. The first thing that we generally do after, of course, completing a thorough neurovascular exam of the patient prior to any splinting, reviewing any radiographs that have been taken, as well as acquiring proper analgesia for the patient, and having our supplies ready. After that point, we talk to the patient to make sure they know what we're going to do, and then we're ready to splint. So the first thing that we do generally is get the patient in some sort of traction, if it's a distal radius or a carpus fracture. You can either do that with finger traps, or if you don't have any of those available, it's very easy to take some web rail, make a loop, put the loop generally between the index and middle fingers, and then loop it over those two fingers. Gives you a little cinch there. It's very important to remember though that this is somewhat constrictive, so it should not be left on for an extended period of time, as it has the potential to cause injury to the fingers distally. Same with finger traps and some of the other possible traction devices. From there, you can secure it to an IV pole. Just make sure that it's adequately secured and doesn't have a chance of dropping the patient's arm. Height you can always adjust by changing the bed height as is necessary to make it a little bit easier. You can easily cut off any remaining. If you are using a IV pole, most commonly they do have these rings on them. Just be careful in that that's not for an extended period of time, pushing into the patient, as that can cause some skin irritation damage. From here, you can check easily with C-arm, making sure if there's any fracture reduction that needs to occur. That's easily done at this point. Then we wrap with our cotton web roll. Always a minimum of 4 layers at the top and at the bottom. It's very easy to extend it past where your plaster is going to be going, because it's very easy to tear the web roll. Make sure to pad between the thumb. This can be done a number of ways. They're easy to make little pants. Wrap that around kind of in a spike almost to the thumb. Also, to really get a nice layer at the top, it's easy to take a long piece, fold it in half, and wrap that there. It's nice to have your patient kind of move as far as they can on the bed too. Really allows access, you're okay, but it allows access to the elbow. If you're doing a long arm splint, you can easily go up the arm. From there, continue down the arm. Try to avoid excessive wrinkles. It's very simple to tear those out.
Why do you avoid the wrinkles?
Avoid wrinkles so that they don't cause any excessive pressure points. Here, even with a short arm, it's kind of nice to go into the antecubital fossa a little bit or pad the elbow a little bit so that you make sure that if you do extend a little bit far, that there's no plaster touching the skin. But always make sure you're kind of aiming for maybe an inch above the antecubital fossa, so make sure you have a minimum of 4 layers there. Don't overpack the antecubital fossa, one, in somebody who you don't need to get stability of the elbow or rotational control. That can constrict there, and so make sure if you do have web roll in the antecubital fossa, you can easily pluck that away. Next, we take our plaster, dip it, laminate. Make sure to laminate very well. We have our one that we specially cut that has a little bit of a thumb recess. That goes up. You can fold it back if you need to. If it's going, you want to make sure you end at the level of the metacarpal heads. Try to bend back any hard corners so they become hard and sharp and can poke into the skin. Generally, try to do volar slab first, and then dorsal slab doesn't really matter. Make sure you end at the level of the metacarpal heads on the dorsal aspect. If you need to bend it back, cut it. Just make sure you're not leaving any sharp angles. From here, put a quick layer of web roll. This aids in removal of the splint. As the bias gets really sticky and stuck onto the plaster, and makes it hard to remove later. You want to make sure you've got very adequately padded ends of where your plaster is. Next, take our bias, wrap it around. Not a big fan of cutting holes in bias, as I think that for the thumb, as that could potentially shift and cause constriction. Alternatives are one, you can just go straight over, or you can do the two turn. Makes a nice little turn there, and you're back rolling. Go up around, generally do that twice. Move down the arm. Once again, make sure you cover everything adequately. From here, a little trick can be just to cut it most of the way. Little strand hanging on, let it dangle down, and then it is very simple to just take your tape and while it's got tension on it before it unravels, put a little piece of tape there and pluck that off. There, you can turn it at the tops, pluck away any excessive web roll, making sure you're still covered, plaster's covered. You need to tuck it under a little bit, making sure you're not over constricting in the cubital fossa. Just beautify your splint. And from here, if you need to do any reductions, this is the time to do it before your plaster gets hard. So if you're doing a distal radius reduction, we use ligamentotaxis, we've got our traction pulling up, push on the carpus to reduce your fracture in the appropriate direction after reviewing your radiographs. If you need even a little counter traction at the bottom, that's very simple to do. We're using the carpal ligaments to reduce any fractures as long as they're intact. Good paper by AG on that. The link we can put at the bottom or attached to the screen. At this point, it's very important to maintain your reduction and your reduction maneuver until the plaster is hard. If you release too early or take your traction off, then you can lose your reduction. Once your plaster is hard, it's very easy, or at any point, to bring your C-arm in, take radiographs in the appropriate planes. If we did want some added traction before applying this, it's very simple to make a little traction device. So we can have a link to that or show it, and then broadly apply it to the arm and allow the patient to hang in some traction for a period of time. This can easily then be cut off or removed once the plaster is hard or at any time. And there, easy to cut it off. And then from here, as long as we like our reduction, we're happy with our splint, move on to securing your bias with tape. Always take pride in your work. This is a good time to allow the thumb and a carpal to be free. Easily cut that back, making sure not to cut the patient, cut away any dog ears you might have. Bias. Cut your patient free. From there, you can continue to tape and secure the bias as you need. Always make sure once you are done with your splint that you perform a thorough neurovascular exam. If there's any negative changes, think about removing your splint or what might be causing that. Always check the tops and the bottoms, making sure that your plaster is well padded and not irritating the skin where it can cause ulcers or pressure issues.